Today, we are going to discuss the anesthetic approach for patients undergoing laparoscopic cholecystectomy, along with the important clinical reasoning behind every step shown in this image. Even though laparoscopic cholecystectomy is considered a routine and minimally invasive surgery, it produces significant physiological changes inside the body, especially affecting the cardiovascular and respiratory systems. Because of this, anesthesia management plays a crucial role in ensuring patient safety, surgical success, smooth recovery, and prevention of complications. The anesthetic journey begins with preoperative assessment and optimization. Before surgery, the anesthesiologist carefully evaluates the patient's overall health condition and associated comorbidities such as hypertension, diabetes mellitus, obesity, respiratory disease, and cardiac disorders. Since this surgery involves the gallbladder and hepatobiliary system, liver function tests become extremely important. Investigations such as bilirubin, liver enzymes, amylase, and lipase are reviewed to identify biliary obstruction, pancreatitis, or liver dysfunction. The patient is also assessed for jaundice, fever, or signs of cholangitis, because infection or sepsis can increase anesthetic risk. Medication history is equally important, especially if the patient is taking anticoagulants, antiplatelet drugs, antihypertensives, or diabetic medications. Another key part of preoperative planning is assessing the risk of postoperative nausea and vomiting, commonly called PO&V, because laparoscopic surgeries have a high incidence of nausea due to pneumoperitoneum, anesthetic drugs, and opioid use. Therefore, antiemetic prophylaxis is planned early to improve recovery and patient comfort. After the patient is shifted to the operating room, anesthesia induction and airway management begin. Laparoscopic cholecystectomy is usually performed under general anesthesia with endotracheal intubation. General anesthesia is preferred because the surgery requires complete immobility, controlled ventilation, and airway protection. Standard monitoring such as ECG, blood pressure, pulse oximetry, capnography, and temperature monitoring are attached before induction. The patient is pre-oxygenated to increase oxygen reserve before administering anesthetic drugs. Propofol is commonly used for induction because it provides rapid onset and smooth recovery. Opioids such as fentanyl may be given to blunt sympathetic responses during laryngoscopy and surgery. Neuromuscular blocking agents like rocuronium are administered to produce muscle relaxation, which is essential for laparoscopic procedures because adequate abdominal relaxation improves surgical visualization and prevents patient movement. Once paralysis is achieved, the airway is secured with an endotracheal tube and correct placement is confirmed using capnography. Controlled mechanical ventilation is then started because spontaneous breathing is usually inadequate during pneumoperitoneum. The anesthesiologist adjusts tidal volume and respiratory rate carefully to maintain normal carbon dioxide levels. Along with anesthesia induction, multimodal antiemetic therapy using drugs such as ondansetron and dexamethasone is commonly administered to reduce postoperative nausea and vomiting. One of the most important intraoperative considerations during laparoscopic cholecystectomy is patient positioning. The patient is placed in reverse Trendelenburg position with slight left tilt. In this position, the head end is elevated and the body is tilted slightly toward the left side. This allows the abdominal contents and bowel loops to move away from the gallbladder, giving the surgeon better visualization and easier access. However, positioning also affects circulation because elevation of the head can reduce venous return and contribute to hypotension. Therefore, the patient must be secured properly to prevent sliding from the operating table, and pressure points must be padded carefully to avoid nerve injuries. Throughout surgery, continuous monitoring of blood pressure, oxygen saturation, heart rate, and ventilation remains extremely important. Another major component shown in the image is pneumoperitoneum and its physiological effects. During laparoscopy, carbon dioxide gas is insufflated into the abdomen to create working space for the surgeon. This increases intra-abdominal pressure and produces significant respiratory and cardiovascular changes. The elevated abdominal pressure pushes the diaphragm upward, reducing lung compliance and decreasing functional residual capacity. As a result, airway pressures increase and ventilation becomes more difficult. To compensate for this, the anesthesiologist increases minute ventilation and continuously monitors end-tidal carbon dioxide levels. Carbon dioxide absorbed from the peritoneal cavity can increase blood C-OTWO levels, leading to hypercarbia if ventilation is inadequate. Capnography, therefore, becomes one of the most important monitors during laparoscopic surgery. Pneumoperitoneum also affects circulation by increasing systemic vascular resistance and altering venous return. Some patients may develop hypertension, while others may experience hypotension depending on intravascular volume status and cardiac function. Rapid insufflation may also stimulate the vagus nerve and cause bradycardia. Because of these physiological changes, the anesthesiologist must constantly balance ventilation, oxygenation, fluid management, anesthetic depth, and hemodynamic stability throughout the procedure. Pain management is another important aspect highlighted in this image. Modern anesthesia practice emphasizes multimodal and opioid-sparing analgesia. Instead of relying only on opioids, multiple analgesic techniques are combined to provide effective pain relief with fewer side effects. Non-opioid drugs such as paracetamol, NSAIDs, and low-dose ketamine may be used. Regional anesthesia techniques such as tap block or local anesthetic infiltration around port sites can significantly reduce postoperative pain. By minimizing opioid use, the incidence of nausea, vomiting, sedation, and respiratory depression can also be reduced. This approach improves patient comfort and supports enhanced recovery after surgery, commonly called ERAS protocols. As surgery nears completion, the anesthesiologist prepares for emergence and extubation. Residual neuromuscular blockade must be reversed completely using reversal agents so that the patient can breathe adequately after extubation. Before removing the endotracheal tube, the anesthesiologist ensures that the patient is awake, maintaining oxygenation, following commands, and generating adequate spontaneous breathing efforts. Smooth extubation is important because excessive coughing or straining may increase abdominal discomfort and stress on surgical sites. Finally, the postoperative phase focuses on monitoring, recovery, pain control, and early mobilization. In the recovery room, the patient is monitored for airway patency, oxygen saturation, respiratory function, hemodynamic stability, pain, and nausea. Postoperative nausea and vomiting are assessed and treated aggressively because they are common after laparoscopic surgery. Pain management continues using multimodal strategies to maintain comfort while reducing opioid requirements. Surgical wounds and abdominal signs are also evaluated to identify complications early. Early mobilization and early oral intake are encouraged because they reduce complications such as atelectasis, venous thrombosis, and delayed bowel recovery.